start. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on management of non-small cell lung cancer in 2023. And with immense pleasure, I would like to invite Dr. Meher Lakshmi, who is Associate Professor of Medical Oncology, Nizam Institute of Medical Sciences, Hyderabad, for the welcome and introductory note and to set the ball rolling. Over to you, ma'am.
Thank you. Also, I'd like to thank the organizers for giving this opportunity. And we all know that there are many advances in the past decade in the management of lung cancer, especially non-small cell lung cancer. We'll quickly go through all the recent advances and also with an emphasis on early stage lung cancer. So the first speaker would be Dr. Josna. Josna is a medical oncologist from Omega Hospital, Hyderabad. She'll be talking on the overview of lung cancer. Dr. Josna.
Thank you, ma'am. I'll share my screen. Is my screen visible?
Yes, ma'am.
Yes.
Yeah. So, I'm Dr. Jyotsna, consultant medical oncologist from Omega Hospital. And without wasting any time, I'll just go to the topic. Today's my topic is on. Yes.
Ma'am, can you make it full screen? It's not.
Yeah, it's full screen in my system.
Actually, ma'am, it is not showing in the screen over here.
You can just check it again. It is full screen now. Can you see?
No, ma'am, not still.
Are the slides moving?
No.
Slides are also not moving.
Ma'am, when first make it full screen, then select from Zoom to share the screen on the.
Okay. Yeah. Okay, understood. 1 second. But after making full screen, I am unable to share. Is it now?
Yeah, perfect, ma'am. Perfect.
Is it full screen?
Yes, full screen. Perfect.
Okay, done. Thank you. So, overview of lung cancer. The burden of lung cancer in India as per Globocan 2020. Both sexes together, lung cancer stands 4th. And in males, it is second in incidence. Regarding staging, from 7th to 8th edition, we can see there is a change, especially the size 3 to 4 centimeters. So previously it was 3 to 5 centimeters, which was 2A, and now it is 3 to 4 only in 2A. Why is this important? Because in the previous trials where adjuvant chemotherapy has been defined, they say it as 1B. But now if we see, the indication more than 4 centimeters come into stage 2. So we should be careful when we talk about directly staging in choosing adjuvant chemotherapy. It is better is more than 4 centimeters to remember. But even in the 1B stage currently, based on the high risk features, there is still a role of adjuvant chemotherapy, which I will be discussing in further slides. And the tools for staging, we have CECT chest, we have bronchoscopy, PET-CT whole body. For mediastinal staging, especially EBUS or EUS, mediastinoscopy, and for metastasis in brain, we have MRI brain. So depending on the stage, we do choose our modalities, which all for the staging.
Ma'am, sorry to interrupt. Still your slides are on the same page. Page number 2. I guess it's not on the full screen mode.
No, it's full screen.
Can you share in the WhatsApp? I'll share on my side.
Yeah, one
WhatsApp group. Did you send?
I'm working on it. 1 second.
Ankit,
Yes,
ma'am.
ma'am.
shall we go to the second talk meanwhile?
Yes, we
If
can.
if it's okay with Dr. Josna.
Yeah, I don't mind actually.
Okay, okay. Meanwhile,
But the
you can
thing is,
share.
after overview only, I think next topic comes. It's in that sequence.
It's no problem. You can share, and meanwhile they'll be ready.
Yeah.
If Monica is ready, we'll go to the second talk.
Yeah, no problem.
Dr. Monica, are you ready?
Yes, ma'am.
Yes, then we will quickly go
Yeah.
ahead with the
Yeah, yeah.
essential biomarkers
Sure, ma'am.
in the treatment of non-small cell lung cancer. Dr.
Yeah.
Monica is a medical oncologist from KIMS Hospital, Hyderabad. Over to you, Monica.
Yeah, ma'am. I'm sharing my screen. I hope I'm audible.
Yes, yes.
And you
ma'am.
can see my screen, right?
Yeah, it's full screen. You can go
Yeah.
ahead.
Yeah. Good evening, everyone. And thank you very much, organizers, for this opportunity. Thank you very much, Meher Lakshmi ma'am, for giving me this opportunity. So in the next 10 minutes, quickly, I'll take you through molecular biomarker testing in lung cancer. What are the advantages and disadvantages of tissue biopsy versus liquid biopsy, next generation sequencing, RNA versus DNA-based techniques. I'll take you through the burden of lung cancer in India, biomarker testing in NSCLC. Why is it important? How the biomarker testing has evolved? How was it in the past and how is it at present? And what are the key takeaways? As per the Globocan 2020 data, we know that overall, both in males and females put together, lung cancer it's in the 4th position. And if you take only males, it's in the 2nd position after lip and oral cavity cancer. So it's the 2nd most common cause in males. And even mortality-wise also, it's in the 4th position. 50% of the patients with advanced non-squamous NSCLC have a driver mutation that is targetable with an FDA-approved agent or on a clinical trial. These are the various mutations. If you see here, and also the drugs, we all know that these are the drugs which are available for individual mutations. Most common mutation is KRAS. Of course, we just have sotorasib and adagrasib. That's a recent addition. And this is still probably not, this is FDA approved sotorasib, but not being used so much clinically. It's not available here for us. And the other common one that we target is EGFR sensitizing mutations that are seen in about 17% of the patients. 7% of the patients have ALK mutations. The remaining mutations like MET, HER2, ROS1, BRAF, RET, NTRK, PIK3CA, MEK1, they are seen in a small percentage of cases, anywhere between less than 1 to 3%. And there are some unknown oncogenic drivers which are detected in about 30% of the patients. The importance of biomarker testing in non-small cell lung cancer, we know that studies have shown clearly that patients who have an identified actionable mutation, who receive appropriate targeted therapy, they have improved outcomes. So if you see here, definitely their median OS, when there's a driver mutation and they're treated with the targetable therapy, the OS is about 18.6 months. Whereas without targeted therapy, when we treat with conventional chemotherapy, it's only 11.4 months, which is statistically significant. So that's why biomarker testing is so important. What are the recommended guidelines for routine biomarker testing to guide treatment decisions in advanced NSCLC? Almost all the guidelines like ASCO, NCCN, ESMO, and the CAP IASLC guidelines also recommend biomarker testing. ASCO and NCCN recommend all these markers, including NTRK fusions, PD-L1 expression, HER2 amplification also. So the NCCN and CAP IASLC AMP guidelines also suggest testing for KRAS mutation, because presence of KRAS mutation, this is more for prognostic. Although we have a drug, this is more of a prognostic. We know that KRAS mutation indicates a poor prognosis, and patients with a KRAS mutation are unlikely to benefit from further molecular testing. ESMO and NCCN guidelines include additional biomarkers that should be tested based on data that were not available when the CAP-IASLC guidelines were developed, illustrating the rapid progress in targeted treatments that's happening in NSCLC. So we are going ahead in leaps and bounds. We have various methods of tissue testing in NSCLC. We have the DNA sequencing, NGS PCR, RNA sequencing panel, IHC, and FISH. The DNA sequencing by NGS or PCR detects insertions, point mutations, deletions, detects aberrations in EGFR, KRAS, BRAF, HER2, MET. Single gene or full NGS panels may be used. RNA sequencing panel, the most important advantage is that it detects fusion abnormalities which are missed in DNA sequencing often. And this is more sensitive for ALK, ROS1, RET, NTRK because these are all fusion-based mutations. Basically, they're fusions. And IHC and FISH detects ALK, ROS1 fusions, highly specialized. It can be faster because we know the turnaround time is lesser as compared to RNA sequencing or DNA sequencing. And IHC detects ALK, ROS1. Again, IHC is a much more easier test, faster turnaround time. Of course, it's not reliable or sensitive enough to guide treatment, and we always confirm it. We need to confirm it with FISH. And IHC is also used to detect PDL1. So how has the biomarker testing evolved in the last few years? So look at the tissue journey, biopsy to analysis. After the preliminary diagnosis, we have biopsy methods and specimen processing. So we get tissue from resection, excision, or small tissue samples, which are made into the FFP blocks. We have fine needle aspiration, exfoliative cytology for lung. It's collected either bronchoscopically, most often, sometimes from the sputum also. We get pleural fluid cytology also, and a cell block can be prepared even from pleural fluid cytology. And then we have liquid biopsies, which are mainly done on blood. It may be done on cystic fluid also, probably not very relevant for lung cancer. And so we need for tissue, we obviously need surgeons and pathologists and other allied health professionals. And histology, cytology, the DNA assessment methods, PCR, cancer gene panels, MSI, whole exome sequencing, whole genome sequencing, targeted mutations, and RNA, we assess by RT-PCR, gene expression panels, and RNA sequencing. Protein, we know we assess by proteomics. So for this also, we need bioinformaticians, data analytics, clinical informaticians, lab staff, pathologists are needed for this. Biopsy, it establishes diagnosis, determines the histologic subtype, and biomarker testing. Histologic subtype, squamous or non-squamous, it's very important. For biomarker testing, primary tumor and metastatic lesions, both are equally suitable. However, bone biopsy can be suboptimal because decalcification has to be done. That causes degradation of the DNA. Liquid biopsies use cell-free DNA in the plasma. They are another option in patients in whom biopsies, they are unfit for biopsy or they are too sick. And we test for EGFR, ALK, ROS1, BRAF, V600E mutation predominantly, NTRK, RET, MET, exon 14 skipping mutation in all non-squamous NSCLC. Using broad NGS testing to detect most mutations is very economical in the sense that tissue-wise, it uses the least amount of tissue. For squamous NSCLC, we do consider testing in young, never or very light smokers, or if biopsy specimen is of mixed histology, then like sometimes we get adenosquamous histology. So that time, even in squamous, in selected cases, we do test for these mutations. And test for PDL1 expression in all NSCLC patients is important. Completion of testing within 10 to 14 working days of biopsy is recommended. So the circulating tumor DNA testing has the potential to be applied across all stages of NSCLC and throughout the treatment pathway. So a diagnosis and treatment selection, the ctDNA genotyping is recommended for clinical use in advanced NSCLC to guide treatment selection under specific circumstances. In resectable NSCLC, ctDNA testing is not part of current clinical recommendations, but it may be applied in this setting in the future as a biomarker. And for monitoring prognosis, response to treatment, and progression or relapse of disease, ctDNA has several potential applications to predict, monitor clinical progression or recurrence in both early stage and advanced NSCLC. ctDNA testing overcomes some major challenges associated with tissue testing because it's minimally invasive for patients, allowing for serial biopsy if needed, if monitoring is needed. ctDNA in the bloodstream is comprised of DNA from all tumor sources in the body. So it captures both tumor heterogeneity and tumor changes over time. And it can be repeatedly done any number of times because it's just a simple blood sample. ctDNA testing may never replace tissue biopsy entirely. This is very important, but it could have a very, very important complementary role to support treatment selection in patients with NSCLC. ctDNA may be used to detect MRD after surgery in resectable NSCLC. Of course, this is in a very rudimentary stage, so I'll not go much into the detail. There was one TRACERx study that was done that took 24 early stage NSCLC patients and they followed them longitudinally after resection. Phylogenetic ctDNA profiling was done, and it was seen that in the TRACERx study, ctDNA profiling was able to confirm MRD negativity and detect MRD in patients who relapsed even before their disease was picked up by standard imaging. We need additional studies to use it in a more larger scale, whether it can be used in resectable NSCLC, whether it can be used to monitor and predict the disease relapse after the completion of treatment. Here is a very important comparison between tissue and liquid biopsy. So sample acquisition of tumor tissue obviously requires invasive procedures. Liquid biopsy is very simple. Repeat sampling, it's very challenging to obtain tumor tissue repeatedly. Liquid biopsy, as I said, it's very easy. Biology, correlation with histology and cellular phenotype is possible with tumor tissue. That's not possible with liquid biopsy because we can't directly correlate between ctDNA with histology or any cell subtype. It's more reflective of tumor genomic landscape rather than the histology. Sensitivity of assay required, lower tumor cell content is acceptable with sensitive techniques with up to 1 to 10%. Very sensitive methods are required because ctDNA may comprise less than 0.1% of the cell-free DNA. And analytical standardization, it uses a tissue biopsy uses existing validated tissue processing and handling procedures, whereas liquid biopsy, the standards for analytical performance characteristics of cell-free DNA or the circulating tumor DNA have not been established. There are no guidelines that exist regarding the recommended performance characteristics of liquid biopsy. Evidence of clinical utility, we have substantial evidence with tissue for initial targeted treatment selection and subsequent treatment after targeted treatment failure in advanced NSCLC. But in liquid biopsy, the evidence is less. However, it's accumulating for initial targeted treatment selection and subsequent treatment after targeted treatment failure in advanced NSCLC. So these are the multiple genes. This I've already covered. Now, what are the advantages? So NGS has a number of advantages over single gene tests. As the number of clinically actionable biomarkers is increasing day by day, the ability to evaluate all known molecular alterations in a single test has given NGS a major advantage. So if you are looking at one or few molecular markers, higher cost and longer turnaround time is there. So there, a single gene assay as against multiple gene assays is more advantageous with respect to cost as well as turnaround time. But if many molecular markers we want to test, then NGS is more economical and it's also a shorter turnaround time. Lower tissue requirement is there. So that's very important. So NGS versus single gene test, NGS detects a broad range of molecular alterations in a single sample. It may identify new markers that could offer additional treatment options for a patient, new markers for which treatment may not be there now, but it may come in the future, and also provide information to help with development of new and more effective treatments. There is high complexity of workflow. That is the disadvantage. It requires experienced personnel, highly trained personnel. Advancements in the field of NGS are evolving very rapidly. Patients as well as the clinical community must receive sufficient education in this area. So we have different techniques and molecular landscape in NSCLC. We have, again, single gene assays, Sanger sequencing, pyro sequencing. So these are the various assays, and we are mainly concerned with NGS in today's talk. So let us look at a few of the common mutations. So EGFR mutation, we can use the paraffin sections, fresh, frozen, or alcohol fixed specimens can be used for PCR-based assays. Cytology samples are also suitable. Cell blocks are preferred over smears. And if you see the concordance of EGFR mutation in primary versus metastatic, it's quite high. Major discordances between EGFR mutation status in the primary and the corresponding metastatic sites is very, very rare. So in EGFR mutation, do we test it in early lung cancer? Yes, we have the ADAURA trial that has shown that using osimertinib in the adjuvant setting in stage 2B, 1B to 3A NSCLC, it significantly improves the recurrence-free survival as well as overall survival. So we need to consider it even in early lung cancer, at least stage 1B to 3A, we should do EGFR mutation testing. So it's not just restricted to metastatic NSCLC anymore. We are using it. We need to do it even in early stage NSCLC. So what are the advantages of NGS over PCR with respect to EGFR mutation? One study showed that about 48.6% of the EGFR exon 20 insertions that were identified via NGS are missed in a PCR. Out of the 17 most common EGFR exon 20 insertion mutation variants, only 4 can be detected in PCR. So that's why NGS takes precedence over PCR as far as EGFR mutations is concerned. ALK gene rearrangements. In most cases, ALK IHC is 93 to 100% sensitive and specific compared to FISH. False positivity rate is there of about 0.1% with FISH. IHC, however, is less expensive, so more widely adopted. However, we always, whenever it's positive by IHC, we confirm it with FISH. Then ROS1 rearrangements in NSCLC. So this is an algorithm. ROS1, there are two ways of doing it. We can do an IHC first. If it's ROS1 positive, we reconfirm by a second method, that is FISH or any other molecular assay. It could be NGS. Or if we are using FISH first and it's ROS1 positive, then we can consider reconfirmation by a second method. So basically, either by FISH or IHC, if ROS1 is positive, we confirm by another assay. If it's negative by either IHC or FISH, we do not need to go further. So that much concordance is there with respect to true negative between IHC and FISH. So detection of elevated ROS1 protein levels by IHC may provide a very cost-effective screening prior to confirmation by FISH, because IHC is obviously less expensive, FISH is a little bit more expensive. And RAS, so where is the RAS? So this is KRAS mutation. KRAS is the most common mutation, which is found in 25% of the cases, nearly 25 to 30%. And RAS, we know that this is the signaling pathway, and it controls a number of downstream signaling pathways that control cell proliferation and survival. KRAS mutations are mutually exclusive with EGFR and ALK mutations and account for nearly 30% of lung adenocarcinomas. The most common of these are in codons 12 and 13, the G12C variant that's found in 13% of the cases. Single gene KRAS G12C testing can be done, but that's not currently recommended, and it should only be performed as a part of a multi-gene NGS panel. Identification of targeted therapies for patients with KRAS mutation has been hindered because of the protein's structural biology. It has no binding pockets that are large enough for therapeutic agents. Sotorasib is currently approved for patients with NSCLC, and trials of adagrasib have shown potential. Acquired resistance to therapy has been observed, although specific resistance mechanisms are not very well understood. Coming to BRAF mutation, so after RAS, we have the RAF protein, and then that controls the downstream MEK, and then followed by control of cell proliferation and survival. So RAF kinase is involved in these growth signal transfers. BRAF V600E is present in more than 50% of BRAF mutant cases and is thought to be more prevalent in smokers. Non-V600E mutations are also there. Overall, they account for about 1 to 5% of the patients with NSCLC, most commonly in adenocarcinoma. Method of detection, not widely recommended. IHC and PCR are generally acceptable for single gene BRAF testing. NGS is generally used as a part of a multi-gene test panel. BRAF mutations can be targeted with BRAF inhibitors. Addition of a MEK inhibitor can block one possible resistance pathway, but however,
Dr. Monica, can you wind up quickly? Sorry
yes,
to interrupt you. Can you wind up quickly?
It's almost done, ma'am. 2 minutes.
Yes.
Currently approved therapies for BRAF, we know we use a combination of dabrafenib and trametinib. The impact of other BRAF mutations on therapy selection is not well understood. Resistance generally develops via a lot of pathways that bypass the RAF pathway and redirect the cell cycle signaling. MET receptor tyrosine kinase, the MET exon 14 mutation, there's a normal role in embryogenesis. In cancer, this MET exon 14 skipping mutation, it causes an in-frame deletion of the juxtamembrane domain, resulting in increased stability and constitutive kinase activation. It's found in about 3 to 4% of non-squamous NSCLC, 20 to 30% of sarcomatoid cancers. Majority of the MET exon 14 skipping mutations can be detected with DNA NGS, but there's an increased sensitivity with RNA NGS. FISH is definitely not recommended for this. And So RET receptor tyrosine kinase and RET fusions again play a normal role in neural and genitourinary development. The mutations in RET gene rearrangements are seen in about 1 to 2% of the non-squamous NSCLC and 10 to 20% of papillary thyroid cancers. Majority of the RET fusions can be detected by DNA NGS. Again, there is increased sensitivity with RNA NGS. So it's better to use RNA-based NGS panel for detecting RET fusions. NTRK fusion, again, RNA NGS is most sensitive. We have drugs for NTRK. So that's why we need to detect NTRK fusion. That's very important. Reflexing to NGS versus IHC reasonable for NSCLC due to low prevalence of NTRK fusions. And the choice of assay will depend on the institution, resources, and clinical context. And each technique has its own advantages, but best is NGS, especially multiplexed testing. There is less depletion of tissue. Fusion partner can be identified. And even for NTRK fusions, RNA NGS is most important. Lastly, HER2 mutations in NSCLC are present in about 3 to 5% of the NSCLC adenocarcinomas. Mostly they're exon 20 in-frame insertions, mutually exclusive with other mutations, mostly seen in never smokers. It has worse OS than other subtypes in lung cancer mutation consortium. In NSCLC, HER2 mutation and amplification must be identified using a NGS DNA panel. IHC used to assess HER2 overexpression, seen in 59% of the NSCLC cases. So this is the 2020 treatment paradigm for molecular biomarker positive advanced NSCLC. These are all the drugs which are available, which I've shown earlier also. So PD-L1 overexpression, again, this is also important. This is based on IHC platforms. We know we have a lot of IHC platforms to choose from. The concordance is fairly good among the various like SP263, DACO22C3, SP142. The concordance is very good. So it's a biomarker for immunotherapy. It's controversial. We know we have not yet identified the best biomarker to see the responsiveness to immunotherapy, PD-L1, tumor mutation burden, MSI. Like this, there are multiple markers which are being used. So to conclude, biomarker testing in NSCLC has evolved from single gene to multiplex testing. Multidisciplinary meetings help in better understanding of sample and test requirements. Samples should contain adequate tumor content, at least 10% to prevent delay in processing. Ideal TAT is 2 weeks. High throughput platforms such as NGS can be used to screen several genes at a time to provide results within the estimated turnaround time. Thank you very much.
Thank you. Thank you, Dr. Monica, for an extensive talk on the biomarkers. Wow. And what biomarkers to choose. Thank you. If Dr. Josna is back, we'll continue with her talk with the overview of lung cancer. Dr. Josna.
Yes. So, next slide. So the burden of lung cancer in India, as per Globocan 2020, it stands 4th in both sexes together, and it stands 2nd in males. Next slide. Next. So, no, previous one. So the staging, as we see from 7th to 8th edition, here the T2A in 7th was 3 to 5 centimeters, whereas in 8th edition, it is only 3 to 4 centimeters, whereas 4 to 5, it has come in T2B, and group staging comes under 2A. So this is important because the previous trials where they mentioned stage 1B is the indication for adjuvant chemotherapy. Now it has changed. It is stage 2. But even then, in the 1B, which is actually less than or equal to 4 centimeters, there are indications which I'll be covering in next slides. Next. So for staging evaluation, we have CECT chest, bronchoscopy, PET-CT whole body, EBUS, EUS, mediastinoscopy, and MRI brain. Based on the initial tumor size, we have various modalities to choose for staging. Next. So the importance of nodal staging, the lymph node size, short axis more than 10 mm. So if it is only CT, the sensitivity is only 55 and specificity is 81. Adding PET to CT, the sensitivity as well as specificity has increased up to 90 to 95. Next. When to have this suspicion for occult N2, the risk factors being in the trials. So they have seen that the central tumors, size of the tumor, and higher SUV on PET for lymph nodes, we have to have a more suspicion towards N2 disease. So in this, we should be doing more aggressive staging workup. Next. For mediastinal staging, the less invasive procedures like EUS or EBUS, and invasive procedures like mediastinoscopy, either conventional or video assisted, and VATS we have. Next. So in spite of EBUS or EUS, if your clinical suspicion is high for N2, like we have already seen central tumors, more uptake of SUV on PET, so we have to consider for mediastinoscopy. Next. And invasive mediastinal staging, when it is indicated centrally located more than 3 centimeter and extensive infiltration of the mediastinum with no evidence of extrathoracic disease or positive N1, discrete N2. So these are all indications. If a node is already seen, bulky N2 node is already seen on CT, there is no need to confirm it with invasive mediastinal staging. Next. The evolution of therapy in lung cancer. Around 2 decades ago, we have only NSCLC. So after which we have the subgroups, histological breakdown in NSCLC, where we have squamous, adeno, large cell. And then further, we have molecular pathology with EGFR all-cross, and we have today we have 9 to 10. And PDL1 expression with or TMB, tumor mutational burden also today we have. Next. So the current guidelines for either neoadjuvant or adjuvant chemotherapy depends on the stage and the findings during surgery. For a clearly stage 1A tumor, there is no need of any adjuvant chemotherapy. For stage 1B to 2A, where 1B is more than 4 centimeters if it is, so definitely adjuvant chemotherapy there is role. But in the 1B, because of the stage 2A, we have definitely adjuvant chemotherapy role. But in 1B, where it is less than or equal to 4 centimeters, but other high risk features like LVA positive or poorly differentiated or visceral pleural attachment, we have to consider for adjuvant chemotherapy. Stage 2B, again, we have adjuvant chemotherapy role. And from 3A or 3B, there is neoadjuvant chemotherapy role also, with or without radiotherapy in N2 disease. Next. So it's the same slide repetition, except that the surgical resection margins based on which R1 or R2. So whenever feasible for R1 and R2, we have to consider for re-resection. If not, then consider for adding radiotherapy. Next. Next slide, please. So in spite of this initial treatment of surgery, adjuvant chemotherapy, adjuvant radiation, still the recurrence rates are high. Within 5 years, we can see as high as up to 50 to 60%. Next. So this is the latest ESMO guidelines, where clearly more than 4 centimeters is a definite indication for adjuvant chemotherapy. But the 1B disease, where it is less than or equal to 4 centimeters, the other features like I have already mentioned, LVI positive, poorly differentiated or visceral pleural attachment disease, we can consider for adjuvant chemotherapy. Next. So as per the LACE meta-analysis, lung adjuvant chemotherapy evaluation, there is a clear overall survival benefit of around 5.4% at 5 years, adding adjuvant chemotherapy, doublet adjuvant chemotherapy post-surgery from stage 1B to 3A. Next. So how well does the neoadjuvant chemotherapy work? So as we see here, the HR values, neoadjuvant chemotherapy in stages like 3A can be considered either before surgery or before CTRT. So the results are being same as like adjuvant chemotherapy. Next. So after surgery from stage 1B to 3A, just now we have seen through Dr. Monika's presentation that the importance of EGFR testing, even in early lung cancer for adjuvant intent, EGFR testing has to be done, especially for these 1B, 2 and 3A stages, where post-surgery, we can today consider for osimertinib. This is based on the ADAURA trial, where we have an impressive HR rates for disease-free survival, but OS is yet to mature. Next. So with the same indications of 1B to 3A, we have today adjuvant immunotherapy also, atezolizumab, based on IMPAR-010 trial. For patients who are PDL1 more than or equal to 1, we can consider for adjuvant immunotherapy, atezolizumab. Next. So from stage 3A or 3B, where definitely N2 disease is there, discrete N2 or bulky N2, main treatment is radiation plus chemotherapy. As we see the techniques, so previously it was only conventional chemotherapy where side effects were more with respect to the normal lung tissue or heart coming into the field. But as we move from the older techniques to the newer ones, 3D CRT or IMRT, there is more and more of sparing of this normal tissue, and we can better deliver the radiation only to the tumor, thereby improving the survival rates. Next. So coming to SBRT, stereotactic body radiotherapy for early stage, early tumors, especially for N2 disease and less than or equal to 5 centimeter lesions, preferably for a peripheral tumors. So we have SBRT where we can give high fraction per radiation with radical intent, especially for patients who are unresectable for surgery, initial surgery, either medically unfit. So we can consider for SBRT. Next. So ahead of IMRT, we do have today respiratory gating 4D CT technology for planning with respiratory gating with image guided radiotherapy. Ultimately, we can be able to give adaptive radiation and the end result being lower and lower volumes of the normal tissues receiving the doses. Hence, better sparing of the normal tissues. Next. So post CTRT for these advanced tumors where clearly N2 is present. So post CTRT based on Pacific trial in patients who are not progressive on CTRT, that is CR, complete response, partial response or stable disease, we can consider for maintain consolidation immunotherapy with durvalumab. This is based on Pacific trial. Next. So we have a demonstrated 5-year survival rate of around 42.9%. Next. So the newer emerging treatment paradigms in metastatic NSCLC, the targeted and immunotherapy. Next. Just now we have seen in Dr. Monica's presentation that when, how, and what, when, and how to do these molecular testing in patients with metastatic NSCLC. So today we have so many molecular targets, either in first line or in second line and third lines. So it is always better to do NGS panel so that in one go we'll be able to get maximum information along with IHC based on the specific platform which for which immunotherapy you are considering. Next. So here is the list of the various targeted therapies on left side and immunotherapies on right side, from which year they have been approved based on the target. So as we see here, 2011, it was initially crizotinib for ALK positive, followed by erlotinib for EGFR. So like that today, the latest one by 2020 was brigatinib for ALK positive. And in immunotherapy also from 2016 with pembrolizumab in NSCLC, till 2020, where we have nivolumab plus ipilimumab along with chemotherapy. Next. So as we can see here, based on the targeted therapy, EGFR in patients with EGFR positive, based on FLORA, the first line osimertinib, we have a PFS of around 18.9 months. And in ALK positive target, where we have alectinib with Alex trial, we have the maximum PFS that can be achieved 35. But above this is lorlatinib, where we don't have the numbers yet, but the HR value is quite impressive. Next. And based on the other targets, even though the incidence is less, 3 to 5, 1 to 2%, but we have various targets in first line therapy. For metaxon 14, we have crizotinib, capmatinib, tenotinib, tepotinib. Rearrangements, we have cabozantinib, vandatinib. NTRK inhibitors, we have larotrectinib, entrectinib. And in HER2 mutations, in second line, we have adotransumab, emtansine. Next. So here, Based on the various molecular targets, either in first line with osimertinib for EGFR, alectinib, brigatinib, or ceritinib for ALK inhibition, RET, selpercatinib, pralsetinib, NTRK, entrectinib, larotrectinib, ROS1, entrectinib, crizotinib, BRAF, dabrafenib with trametinib, and metaxon 14, capmatinib. So from various trials, we can see here that compared to the traditional chemotherapies previously, which we were used to give for non-squamous and adeno, adeno and squamous. So we can see here the difference in the survival rates, which has improved quite a lot. Next. So immunotherapy, mainly after doing the IHC based on PD-L1 testing, CPS more than 50, TPS more than 50 or 1 to 49, either combining with chemotherapy or giving single agent immunotherapy. We have PD-1 inhibitors, PD-L1 inhibitors. Next. So here we can say again, comparing with the traditional chemotherapy in non-squamous and squamous, immunotherapy either in combination with chemotherapy for 1 to 49 TPS or
Josna, Dr. Josna,
yes,
can you wind up quickly, please?
Yes,
We're
yes,
sitting in time.
slides. Yes, ma'am. So either immunotherapy alone or immunotherapy along with chemotherapy, we have quite impressive survival rates compared to the traditional on chemotherapy. Next. Next. So this is for an example keynote 024 trial where it has showed improved survival in patients with pembrolizumab compared with chemotherapy in PD-L1 TPS more than 50%. Next. So in adjuvant intent as well as neoadjuvant intent, we are there are many trials ongoing for adjuvant immunotherapy and neoadjuvant immunotherapy. Next. So mainly the key takeaway is that the management landscape is fast changing in NSCLC. The newer therapies have a huge potential to improve survival, especially when detected in early stages. Overall survival has improved across various subtypes with molecular alterations. Ease of oral pills over infusions in case of targeted drugs is an added advantage, and the pulmonologist will play a huge role in early diagnosis. Hence, it is crucial to involve them in NSCLC tumor boards. Thank you.
Thank you, Dr. Josna, for the extensive lecture on the overview of lung cancer. The next talk will be by Dr. Rachna on ADAURA trial, that is osimertinib in early EGFR mutated non-small cell lung cancer patients. Dr. Rachna is assistant professor in medical oncology at Nizam Institute of Medical Sciences, Hyderabad. Over to Dr. Rachna.
Good evening, ma'am. Thank you for giving me this opportunity, and thank you, AstraZeneca, for this opportunity. Can I share my slides?
Sure, ma'am.
Can you see my slides?
No, ma'am. Should I share from my side?
Yeah, you can do that if you're not able to see from my end.
Is it fine, ma'am?
Yes. I've sent a mail to you actually, the slightly edited one.
This is the one, ma'am.
Just now I sent a mail. to the Lung Cancer Connect, which I have shared the email ID. It's not available.
1 second. Yeah. Can you see my screen?
Yes, yes, yeah. Okay. Good evening again. So I'll be discussing about the ADAURA trial, which is the role of osimertinib in early EGFR mutant NSCLC. Next slide, please. So this was all discussed and everyone knows about this, that NSCLC represent the 85% of the lung cancers with an estimated 30% of the patients presenting with a resectable disease at diagnosis. And the NSCLC localized can be divided into early stage and locally advanced. Early stage being stage 1A, 1B, and locally advanced is stage 2 and 3. Next slide. Next, please. And coming to the outcomes in early stage NSCLC, surgery is the primary treatment modality, and addition of adjuvant chemotherapy has resulted in an absolute improvement of 5% survivals at the time of 5 years. And this can be further improved by using targeted agents. And the disease recurrence rates also varies with stage as expected, with the 5-year recurrence at stage 1B being 45%, 62% recurrences in stage 2, and 76% in stage 3. Next slide. Next, please. We have a limited number of studies to give us information regarding the prevalence of EGFR mutations, both in the localized and the advanced stage. But broadly, all these studies have given a similar estimates for the advanced NSCLC and the localized NSCLC, seen in around 30 to 40% in Asians and around 20% in the Caucasians. Next one. These were all the trials before ADAURA trial, including the EGFR mutation targeted agents, erlotinib and geftinib. Select Radiant and the IVAN trials have used erlotinib versus adjuvant chemotherapy or placebo, and adjuvant or the BR19 trial have used geftinib. Though some of the results were positive in these trials, none of these drugs are approved for use in the adjuvant setting. Next slide. Coming to the trial proper, the ADAURA trial, which is the osimertinib as an adjuvant therapy in patients with stage 1B to 3A, that is the resectable NSCLC patients, after complete tumor resection. Next slide. So this is the study design. Patients with or without adjuvant chemotherapy have been randomized to receive osimertinib 80 mg for 3 years or placebo once daily. And the treatment was continued till disease recurrence or the treatment completed, that is 3-year time point, or if any discontinuation criteria has been met. The primary endpoint was disease-free survival, and the secondary endpoints was disease-free survival in the overall population. The primary was the disease-free survival in stage 2 and 3A patients only, whereas the overall population is stage 1B, 2, and 3A. Next slide. These are the inclusion and exclusion criteria. It included all adults more than 18 years of age who are post-operatively staged by 1B and 3A. There should be a confirmation of the EGFR mutation, and the person might have or might not receive post-op adjuvant chemotherapy with 4 cycles of cisplatin or platinum-based chemotherapy maximum, and might have undergone a complete surgical resection, and proper imaging should be done, that is the imaging of the brain to rule out any metastasis, and with a good performance status. They have excluded patients who have received any form of radiation pre or post-op, or those patients who have received a neoadjuvant chemotherapy or received a TKI prior. And time between surgery and randomization is not more than 10 weeks if no adjuvant chemotherapy was used, and not more than 26 weeks if adjuvant chemotherapy was used. And they also excluded patients who did not undergo lobectomy, that is, who have received only wedge resections or segmentectomies. Next slide. The baseline characteristics were well matched between the osimertinib and the placebo group, and adjuvant chemotherapy was given in 60% of patients in both the arms. Next slide. Coming to the disease-free survival, the primary endpoint of this trial, the disease-free survival in stage 2 and stage 3A was significantly improved with the usage of osimertinib compared to placebo. The median disease-free survival not being reached at the 3-year time point, and the placebo is 19.6 months, the median disease-free survival, hazard ratio being 0.17. And coming to the overall population, which included all the 3 stages, that is 1B, 2, and 3A, the disease-free survival is still significant. Next slide. So there's a 83% reduction in the primary study population and 80% reduction in the disease recurrence in the overall study population. Next slide. And the 2-year DFS was consistent for the osimertinib arm across all the disease stages, that is 1B, 2, and 3A, with the hazard ratios being 0.39, 0.17, and 0.12. Next slide. Coming to the subgroup analysis, we can see from this forest plot that all the subgroups have benefited with the usage of osimertinib compared to placebo. A slightly lesser benefit in the stage 1B, but still the benefit is persistent with the hazard ratio being 0.39. Next slide. And this is a snapshot of the overall survival. The overall survival data is still immature and the hazard ratio is 0.40. The maturity is only 5%. And the patients and the investigators still remain blinded till the OS data is mature. Next slide. Coming to the type of disease recurrences in ADAURA trial, the total disease recurrences were seen in 11% of the patients in the osimertinib arm compared to 46% patients had a recurrence in the placebo arm. And these recurrences also, the patients who received placebo, majority had a distant recurrence. That is 61% of the patients on placebo arm had distant recurrences compared to only 38% of the patients who have received osimertinib. Next slide. Why is the type of recurrence important? It is important because those patients who have a local or regional recurrences fare better than those who have a distant recurrences. And those patients with the CNS recurrences have a poorer survival compared to those with the non-CNS recurrences. And CNS is a common site of distant recurrence post-adjuvant therapy, especially in patients with any EGFR mutation or ALK mutation. In the adjuvant RADIANT trial, they have seen that 37% of the patients had CNS recurrences. And we know in the metastatic setting, osimertinib is the TKI which has shown a benefit in the CNS disease also, as it has a greater penetration of the blood-brain barrier. Next slide. So these are the sites of disease recurrences observed in the ADAURA trial. 11% versus 46% in the placebo arm, and the CNS recurrences were seen in 1% of the patients only in the osimertinib arm. Next slide. Overall, 45 patients had a CNS disease-free event, but the CNS recurrences were seen in only 4 patients, which is only 1% of the total study population. Next slide. This is the Kaplan-Meier curve of the CNS disease-free survival in the overall population. The median CNS disease-free survival is not reached in the osimertinib arm compared to 48 months in the placebo arm with a hazard ratio of 0.18, which is almost similar to the overall disease-free survival. Next slide. And coming to the adverse events, any adverse event was noticed in most of the patients in both placebo arm and also the osimertinib arm. Grade more than or equal to 3 adverse events were seen in 20% of the patients in the osimertinib arm and 14% in the placebo arm too. And discontinuation because of adverse events was seen in 11% of the patients in the osimertinib arm. Next slide. The most common adverse events as expected with osimertinib were diarrhea, paranoia, dry skin, and pruritus. The dreaded complications of interstitial lung disease were seen in only 3% of the patients, and QTc prolongation was reported in 7% of the patients in the osimertinib arm. Next slide. This is another data from the same ADAURA trial with the outcomes based on the post-operative chemotherapy. Next slide. As discussed earlier, 60% of the patients have received adjuvant chemotherapy with a platinum-based regimen with a maximum of 4 cycles, and 40% did not receive adjuvant chemotherapy. And this was similar in most in the stage 2 and stage 3A, but patients in stage 1B were the most common patients who did not receive adjuvant chemotherapy. Next slide. So disease-free survival in patients with the overall population. With adjuvant chemotherapy, the 2-year disease-free survival was 89% versus 49%. And those who did not receive adjuvant chemotherapy also, we have a similar benefit of 89% versus 58% DFS at 2 years. The hazard ratios being 0.16 for those who have received adjuvant chemotherapy and 0.23 for those who haven't received adjuvant chemotherapy. Next slide. And disease-free survival in patients with and without adjuvant chemotherapy by disease stage, that is in the stage 1B, 2, and 3A. We can see that in all the subgroups, the disease-free survival advantage was seen with osimertinib in patients who have or have not received adjuvant chemotherapy. Next slide. So this is for the stage 1B patients. This is the only subgroup, the stage 1B, who have received adjuvant chemotherapy. We can see the crossover of the curves with osimertinib or without osimertinib. The hazard ratio is inconclusive for stage 1B patients who have received adjuvant chemotherapy. And coming to those without adjuvant chemotherapy, even in stage 1B, osimertinib has shown a disease-free survival advantage over placebo. Next slide. And we have to remember that this staging was based on the AJCC 7 staging, not with the AJCC 8, in which, as Dr. Josra has already mentioned, there's a change in the size of the tumor from stage 1B to 2 in the AJCC 8. So we have to be careful while interpreting this data. And coming to stage 2, both with and without adjuvant chemotherapy, disease-free survival has improved with the usage of osimertinib. Next slide. Similarly, with stage 3A, we can see the wide separation of the curves for osimertinib versus placebo in both the groups of adjuvant and without adjuvant chemotherapy. Next slide. And one of the important topics, that is the patient-reported outcomes from ADAURA trial. Next slide. The health-related quality of questionnaire SF36 was used to assess the quality of life in the ADAURA trial. And the data collection started from the time of surgery, followed by randomization, then week 12, and every 24 weeks after that. Next slide. And we can see that both the curves of osimertinib and placebo are merging together, which indicates that there was no difference in the quality of life in patients who have received osimertinib compared to placebo. Next slide. Coming to the time to deterioration of the physical and mental component summary, even here both the curves are merging together, indicating no difference in the physical and mental component summary for osimertinib compared to placebo. Next slide. So to summarize, adjuvant osimertinib is the first targeted agent in the global trial to show a statistically significant and clinically meaningful improvement in disease-free survival. There is a 80% reduction in the risk of disease recurrence or death with osimertinib. And the 2-year disease-free survivals are 89% versus 52%. And a clinically meaningful DFS benefit with osimertinib was observed in patients with or without adjuvant chemotherapy, regardless of the disease stage. And overall health-related quality of life was maintained. Adjuvant osimertinib will provide a highly effective practice-changing treatment for patients with stage 1B, 2, 3A, EGFR mutant NSCLC after complete tumor resection. Next slide. Thank you.
Thank you, Dr. Rashna, for your excellent presentation. Now we'll have a panel discussion on the management of early stage lung cancer. For this, I'd like to invite the panelists, Dr. Praveena. She's a medical oncologist from Mahatma Gandhi Cancer Institute, Visakhapatnam. Dr. Swarupa, medical oncologist from Mallareddy Cancer Hospital, Hyderabad. Dr. Lakshmi Deepti, medical oncologist from Surya Global Hospital, Kakinada. Dr. Rekha Bansal, medical oncologist from Apollo Hospital, Hyderabad. Dr. Josna, medical oncologist from Omega, Hyderabad. Dr. Aditya, consultant medical oncologist from Max Delhi. Dr. Rachna, again from Hyderabad, NIMS. Dr. Monica from KIMS, Hyderabad. And Dr. Mahati from Omega Hospital, Andhra Pradesh. So I welcome you all for this today's. I'll share my slide. Can you allow me to share my screen? Yes.
Yes, ma'am, you can now.
Yes.
And ma'am, Aditi ma'am has not joined yet.
Aditi is not there. Just inform me when she's back. Okay.
Yeah, sure.
When she joins back, you can just tell me. Okay. So we'll quickly go through a old man who's a non-smoker. He presented with mild cough. X-ray showed a small lesion in the left upper lobe, and the chest CT showed a lesion in the left apical lobe. These are the CT scan of the patient. And this is the adenocarcinoma of lung, which is showing on the CT report. So let us quickly go through regarding diagnostic workup. Dr. Pravina will take this question. What diagnostics tests you usually order when you see such patients? Once you see an SOL in the lung on CT scan and with the biopsy proven endocarcinoma, what additional tests you want to do? Yes, Dr. Pravina. Dr. Pravina is there? Dr. Swarupa?
Yes, ma'am.
Yes.
Ma'am, I would like to do a CT guided lung biopsy for this patient with a posterior approach, probably.
Okay.
And additional testing, I would like to send for EGFR and PDL1 as it is early lung cancer.
So you like to do a
And
CT
one more
scan?
thing, MRI, madam, because more than stage 2, now NCCN also recommends MRI as a part of staging workup.
Okay, so you like to do MRI in all patients or any specific subset of patients?
Whomever I'm planning for definitive curative intent and aggressive CTR.
So whomever you're going to go planning for surgery, you want to do MRI brain.
Yes.
And any other tests? Any other tests?
Mediastinal workup, if
yes, other tests
not
maybe
in this
Dr.
case.
Yes, Dr. Swarupa.
Mediastinal workup, invasive mediastinal workup, at least not in this case, madam, because already PET is negative and PET is quite negative predictive value of PET is high. So probably this
So
being
those patients where PET is negative, you don't want to do a mediastinal workup.
In this case, madam, where tumor appears peripheral.
Okay, and in which patients you want to do mediastinal workup? Can you just elaborate on that?
More than 3 centimeters tumor and with high SUV uptake on PET and with any imaging wise node positivity.
So in and any central or peripheral tumors?
Central tumors I would like to.
So the central tumors you like to do a
An
mediastinoscopy.
Yes.
Am I audible, ma'am? This is Dr. Pravina, ma'am.
Yes. Dr. Pravina, if you're back, can you just tell us whether tissue sampling is a diagnostic challenge in your center and what approaches you usually adopt in your center for lung cancer biopsy?
Yes, ma'am. For peripheral tumors, we usually proceed with CT guided biopsy if the lung is not emphysematous, not having element of cells like that. For central tumors, we usually prefer EVAS guided biopsy. At the same visit, at the same in the same procedure, we can proceed with mediastinal staging also along with the biopsy.
And when do you prefer mediastinoscopy in your patients? The same question, Swarup also.
Notes are highly suspicious on PET CT, but EVAS guided FNACR biopsy has come negative. Then we go with mediastinoscopy, ma'am.
And when do you recommend CT or MRI brain in your patients?
From stage 2 onwards, it is recommended, ma'am. Sometimes if we do PET CT, in that CECT, contrast enhancer CT brain will be there. For some patients, if no suspicious findings are there on CT, then we are avoiding them. If patient is affordable, then we definitely from stage 2 onwards, it is recommended, ma'am.
Okay, so you want to do some stage 2, and Swarupa feels that all patients who want to go for definitive treatment with surgery, she wants to get an imaging of the brain. That's fine. And these are the NCCN recommendations, the usual recommendations which we all discussed. We are not deviating anywhere from the recommendation. And in this patient, EUS has been yes, no enlarged mediastinal scores. He is medically fit. He underwent surgery, and this is the pathological stage, the T2 and 1. And next step. Dr. Deepti. Dr. Deepti, regarding biomarker testing, do you routinely check for biomarker testing in early stage lung cancer? And when do you prefer? Is the biopsy specimen or the post-surgery specimen? And what biomarkers you test? Dr. Deepti?
Good evening, ma'am. Yes, ma'am, we usually send for molecular biomarker testing, even in case of early lung cancer. We usually do the EGFR, ALK, and PDL1 separately from the biopsy specimen, madam.
Okay, so EGFR ALK from the biopsy. You mean
Yes,
the post-surgery or the diagnostic sample or the post-surgery?
Diagnostic sample itself, ma'am.
You answer the if the diagnostic sample is insufficient,
then we do on the post-surgery sample.
So you prefer on the diagnostic sample, and then if that is negative, you want to do in a post-surgery tissue. Why do you prefer to do on the diagnostic sample itself?
Mm,
Maybe you
no.
want to take time by the time you finish your surgery.
Yes,
and
ma'am.
you'll get the
Only for
report.
early diagnosis, madam.
Yes.
That's
So
it.
I understand. So this is the recommendations. As already discussed, we need to check for biomarkers, even early detectable non-small cell lung cancer, especially EGFR testing is a way forward, because now we have numerous good data to support the use of EGFR TK in patients who undergo dissection and those who have a mutation in the EGFR exon. So do all patients in your early stage undergo surgery? I want to know about your practice. Dr. Rekha Bansal from Apollo Hospital can take this question. What percentage of patients undergo surgery? And if not, what percentage they don't undergo surgery? And what are the possible reasons? And what are the factors you consider when you determine resectability? Dr. Rekha can take this question.
Yes, ma'am. Thank you. Good evening, ma'am. So basically, ma'am, I would say that we hardly see any early lung cancer patients. Of course, now with the increasing screening awareness, maybe the pickup rate is high, but most of them end up going to the pulmonologist first, and they might with more and more specialization happening now, we even have a thoracic surgeon. So basically, I'm telling you my experience, ma'am, that most of these patients might end up undergoing a surgery also, and then we might see them for a role of any adjuvant therapy. But basically, early lung cancer patients, I would say they're less than 10% in my practice. And once diagnosed and once convinced, yes, definitely they undergo resection. So I think we should make, like it was mentioned, we should make the pulmonologist more aware how adjuvant therapy has come in, new adjuvant therapy has come in, and even if they pick up early lung cancer, instead of referring to a thoracic surgeon directly, they should probably involve a medical oncologist also.
Okay, that's a very practical approach, Dr. Rekha. Maybe we should educate more and more other doctors also in the forums regarding the need to undergo all these mutations and the need for a multidisciplinary team approach, where a medical oncologist need to be involved because latest advances, the numerous advances are taking place day by day. So all these need education. We need to educate our own colleagues regarding the available treatment options and what best can be offered to the patient. Thank you. And regarding the role of radiotherapy, Dr. Josna, can you elaborate on the role of radiotherapy in early lung cancer? In which patients you prefer post-operative radiotherapy in early stage lung cancer? And any role of SBRT? Dr. Josna? Dr. Josna is around?
When Dr. Josna left for an emergency.
I think Dr. Lakshmi can answer this question. The Lakshmi Deepti. Role of
yes, ma'am.
Yes.
Post-op radiotherapy in case of early stage resected cases only be recommended only in case of margin positive, madam.
Okay.
Margin
fine.
positive or if histopathological if there is node positivity also.
Yes.
Otherwise.
So when the node positivity and those patient margin positivity, and any role of SBRT in early stage lung cancer patients. When
yes, ma'am.
offer...
SBRT can be given in early stage lung cancer patient stage 1A and all if the patient is not suitable for surgery.
Yes, if the patient is
Madam,
medically unfit.
Can I comment?
Yes. Yes, who is that? May I know who is speaking?
Dr. Pravina, ma'am.
Yes, Pravina. Yes, certainly.
Yeah, actually, adjuvant RT previously we used to give for N2 disease and positive margins, ma'am. But after
Yes.
lung trial results have come, but there is no benefit in N2 disease with the adjuvant RT in N2 disease. Now we are giving only for positive margin patients.
Yes, especially when you give chemotherapy, adjuvant chemotherapy, and when you give subsequent lines of therapy. So then the role of coming is becoming less and less. But by and large, N2 disease and postnodal margins are the two cross indications which you all remember as of now. And the role of SBRT, Dr. Pravina, anything else you want to add?
Nothing, ma'am. Actually, for patients who are not fit for surgery, such patients we can offer
Yes. As Dr. Deepti has already discussed, those patients are not fit for surgery, we can go for SBRT. So Dr. Monica can take this question. Role of neoadjuvant therapy in early stage non-small cell lung cancer. What are your thoughts, Dr. Monica? Dr. Monica?
Yes, ma'am. One thing is if some medically unfit patient we want to optimize before surgery, a patient who has bad lungs. So in that patient, I would consider some neoadjuvant chemotherapy, as well as if nodes are positive, ipsilateral nodes are positive, or the tumor is close to any vascular structure, or close to the pericardium resection, a little margin is required. So in such patients, otherwise not something that I use routinely. If resectable, then we send for surgery.
Okay, any thoughts on the role of neoadjuvant immunotherapy in early stage lung cancer? There's recent data actually coming with the role of nivolumab and along with chemotherapy, which has shown good pathological.
Pathological response rates of up to 24% can be achieved with the addition of nivolumab, ma'am.
Yes.
In my opinion, neoadjuvant chemo along with immunotherapy can be considered in single station N2 disease with resectable primary tumor. Such patients, it is beneficial to give NSCLC along with immunotherapy.
Basically, it's the patient should be resectable upfront. The treatmentation needs to be taken in the MDT board, where the patient should be resectable upfront, and those patients where we need to downstage further. We still don't know whether these pathological CRs will translate into improvement in oral survival. That we need time.
Yeah.
So, but as of now, we have data where the CR rates are quite impressive with the use of neoadjuvant immunotherapy. Though it's still not yet practice changing as of now. Maybe in the future, we don't know what the future is going to be. And this patient post-surgery, the molecular panel report as EGFR L8FAR mutated. And what is the role of adjuvant? Dr. Rachna has extensively elaborated on the role of adjuvant therapy. And Dr. Mahati is around?
Yeah, yes, ma'am.
This patient, what is your approach? You want to offer chemotherapy? If so, what? Followed by any other TK?
So this patient is T2N1, so we'll go for adjuvant chemotherapy for 4 cycles, followed by adjuvant osimertinib.
What treatment do you like to offer for this patient?
Ideally, it would be platinum based. I missed out on age and everything, but if they are cisplatin eligible, they'll go with cisplatin plus vinorelbine or pemetrexed combination.
So in your practice, what do you routinely prefer? You prefer vinorelbine or pemetrexed?
Most of the patients we have are elderly patients, so it would be cisplatin with pemetrexed, which is safer. Vinorelbine is difficult to deliver. One thing, we have to plan for a central line and lots of neuropathy complications. So I most often tend to give pemetrexed.
I'm curious. Have you ever delivered? I mean, you say most often. So have you ever given vinorelbine as an adjuvant setting?
Only one patient we have.
Because we never gave. I never gave in my practice. That is the reason I'm curious. So for especially adjuvant setting,
one patient practically.
Okay. And what is your thoughts on adjuvant osimertinib?
Yeah, the ADVA trial it is very promising, but OS data is yet to come. Since it is approved, we would suggest osimertinib, adjuvant osimertinib after the chemotherapy.
So you like to offer 4 cycles of adjuvant chemotherapy, cisplatin based, preferably PEMCA, followed by adjuvant osimertinib. Yes. And I think this was already discussed. Adjuvant chemotherapy and drug regimens. The most common regimen which we follow is especially PEMCIS, cisplatin based. And this is the LACE analysis which was already discussed before, the benefit of therapy, ADAURA trial, which is extensively discussed by Dr. Rachna, and impressive hazard ratios in all the patients' subsets. So Dr. Rachna has already discussed. Dr. Rachna, one last word is ADAURA practice changing. What are your thoughts? If a patient comes to you, what is that you're going to, what are this that you're going to offer to him? Dr. Rachna, one last word. Yes.
With patients for stage 2 and stage 3 completely resected NSC adenocarcinomas, I would like to offer osimertinib with EGFR mutation positive. I would say it is practice changing with the good survivals we are getting from the trial data.
Yes. maybe even though there's no OS data as of now, we just cannot leave the patient, and we need to pass on the benefit of the impressive DFS benefit at least to the patient, needy patient. And I thank all the participants for your active participation and for your inputs. Next, we'll go to the next talk. Next talk is by Dr. Pravina Una. She's a medical oncologist from Mahatma Gandhi Cancer Hospital, Visakhapatnam. She will be talking on the practical approach in the management of EGFR mutated lung cancer. Dr. Pravina. I need to stop sharing, I suppose. Yes.
Yeah. First of all, I would like to thank Mahalakshmi Madam and the Global Oncology Forum for giving me this opportunity. Can you share my slides? Mr. Omkar?
No, Faisal will share more.
Yeah.
Moment. Ankit, kindly play the slide deck. Yeah.
Is it visible?
Yes, it's visible. Can you change the slide? So far, we have discussed extensively about EGFR mutation positive treatment options and all those things. So as we all know, the percentage of Asian EGFR positivity in Asian and non-Asian populations, it is around 40 to 50% in Asian and 10 to 20% in Caucasians. In Indian patients, the incidence rate is in between 20 to 23%. Exon 19 deletions and 21 L858R mutations are most common. Next slide. So we have a lot of options. So first generation EGFR TKIs, second generation TKIs, and third generation TKI, which is the best option. Next slide. Next slide. So osimertinib is new standard of care for first line therapy. Why? Let's get into the data. Next slide. And next. And NCCN guidelines also showing osimertinib as the preferred option for patients having EGFR mutation positive advanced or metastatic non-small cell lung cancer. Remaining all TKIs are other options. So it is for preferred first line treatment. Next slide. So when we compare first generation, second generation, third generation TKIs, there are differences between these. First generation TKIs are reversible. Second and third generation are irreversible. And first generation TKIs bind to the EGFR ATP binding site, whereas second generation bind to the ATP binding site and HER2 also. Afatinib. Osimertinib binds to C797 site, ATP binding site. Next slide. So osimertinib, along with inhibition of exon 19 deletion and L858R mutation, also inhibits T790M. It crosses the intact blood-brain barrier, which other drugs can't do. Next slide. So osimertinib has been approved as first-line therapy based on the results of FLARA study. In FLARA study, they have enrolled locally advanced or metastatic NSCLC cases having EGFR exon 19 deletion or 21 mutations, randomized in 1:1 ratio to osimertinib and standard of care EGFR TKI, gefitinib or erlotinib. So endpoints were PFS, primary endpoint was PFS, secondary endpoints were response rates and overall survival. Next slide. So let's see the results. Median PFS was 18.9 months in osimertinib versus 10.2 months in the other arm with a hazard ratio of 0.46. With a very significant p-value, we can see the early separation of curves also in the slide. Next slide. And coming to forest plot in subgroup analysis showing in all subgroups, PFS benefit is more with osimertinib compared to the other arm. Next slide. This is the overall survival data, and osimertinib patients were more likely to be alive at 2 years and 3 year landmarks, and up to 38 months OS was achieved with osimertinib compared to 31.8 months with in the other arm. So first time an EGFR TKI has translated PFS to a significant OS benefit. Next slide. So 28% of patients were still receiving osimertinib at 3 years, which was 3 times more than patients in the comparative arm. So 22% versus 5% of patients still on treatment at data cutoff. Next slide. Next slide. Yeah, when we compare the data for the all TKIs, so there is significant PFS benefit with osimertinib. For all other TKIs, the PFS was between the range of 9 to 14 months only. 18.9 months PFS was never seen with any prior first generation and second generation TKIs. Next slide. And when we see the forest plot, as I already discussed, in all subgroups, PFS was in favor of osimertinib. In OS also, in all subgroups, OS favored favors osimertinib, but the magnitude of benefit varies. Except in the Asian patients and patients having a late 50R mutations, the benefit was little bit less. But we should not draw conclusions from this because subgroup analysis is not powered. Next slide. Next slide. So next slide. Let's discuss about first generation TKIs. As I already said, with first generation TKIs, so gefitinib or erlotinib, the PFS will be in the range of between 9 to 13 months. And if you see the Indian data, the OS is maximum OS achieved was 21 months in the study by Noronha et al. So this is similar to the survivals reported in global studies, which are very less compared to FLARA OS benefit with osimertinib seen in FLARA study. Next slide. So second generation TKIs, afatinib and decomatinib, these are second generation TKIs. So when we compare, decomatinib was approved based on results of Archer study. When we compare the Archer study design and FLARA study design, in Archer study, brain mets patients were excluded, not included. Whereas in FLARA study, patients having brain mets were also included. Next slide. And if you see the PFS curves, there was immediate separation of curves in FLARA study, whereas the separation of curves was not seen until 6 months in Archer study. Next slide. Whereas in FLARA study, we have seen significant OS benefit, whereas in Archer study, OS was not statistically significant because they have the trial was based on hierarchical statistical design. So p-value could not be given to the OS. So significant OS benefit was not seen. Next slide. So if you see the gross differences between Archer study with decomatinib and osimertinib FLARA study, so as I said, patients with brain mets or leptomeningeal mets were excluded from decomatinib, whereas FLARA study they were included. Median PFS achieved with decomatinib was 14.7 months, whereas 18.9 months with osimertinib. And Kaplan-Meier curves we have seen immediate separation with osimertinib, and median OS achieved was only 34 months with decomatinib. And also, most importantly, the side effect profile. Osimertinib is a good safety profile, whereas with decomatinib, toxicities were higher, and dose reductions were done in 66% of patients, whereas only 3% of patients dose was reduced in osimertinib in FLARA study. And serious adverse events, SAEs were seen in 27% of patients with decomatinib. So tolerability profile and survival benefit, all these are very good with osimertinib compared to decomatinib with Archer study. Next slide. If you compare data for afatinib and osimertinib, so if you and fail to improve overall survival, OS in Lux. Sorry for the interruption. Yeah, am I audible? Yeah, afatinib failed to improve OS in Lux-Lung 17 trial compared to Lux-Lung 7 trial compared to gefitinib. Next slide. And we compare the PFS curves between Lux-Lung 7 Archer study and FLARA study. So in Lux-Lung 7 also with afatinib, until 12 months, the separation of curves were not seen. But these are cross-trial comparisons, not head-to-head comparisons. Next slide. So far we have seen excellent PFS and OS data with the osimertinib in FLARA study and comparison with first generation and second generation TKIs. Let's look at data in patients with brain metastasis. Next slide. Next slide. So brain is a sanctuary site of for EGFR TKIs because all first generation, second generation TKIs are not able to penetrate blood-brain barrier. So isolated CNS progression can occur due to this poor penetration, but osimertinib can penetrate this blood-brain barrier. So it can also acts on the tumor cells in the brain. Next slide. This was proven in the preclinical study. These pictures are showing good intracranial penetration with osimertinib. So it is a blood-brain barrier permeable. Next slide. So it has demonstrated high brain penetration. So in FLARA study, both systemic and intracranial efficacy were analyzed, and osimertinib showed superior efficacy to other drugs in the CNS. So in the LUX-Lung studies, LUX-Lung studies, intracranial response from treatment was not assessed. So osimertinib is the only EGFR TKI to report intracranial efficacy. Next slide. So in patients with known or treated CNS metastasis and patients without known CNS mets, the PFS was in favor of osimertinib in FLARA study. And CNS progression events occurred in 6% of patients receiving osimertinib compared to 15% patients in the other arm. Next slide. So CNS PFS also statistically significant with osimertinib with a hazard ratio of 0.48. Next slide. So the CNS progression rates were very less with osimertinib compared to the other arm. Next slide. So according to NCCN guidelines also for patients, NSCLC patients having EGFR mutation and brain metastasis, osimertinib is the recommended treatment. Next. So let's see the tolerability profiles now. Next slide. As I said, compared to other EGFR TKIs, osimertinib has very good tolerability profile that can be seen from the data from FLARA study. It is in spite of longer median duration of use with osimertinib. In any AE leading to discontinuation was seen only 41%, and the grade 3 toxicities was seen only in 51 compared to 49% in other arm. Next slide. We see in this picture the percentage of adverse events were more with less with osimertinib compared to other EGFR TKIs in the FLARA study. Next. So if you see the data also, then AEs leading to dose reductions were more frequent in patients receiving afatinib in LUX-Lung 7, 41.9%, whereas 66% of patients needed dose reductions in Archer study with osimertinib, whereas only 4% of patients needed dose reductions in FLARA study with osimertinib. Next slide. Next slide. So far we have discussed about survival benefit and also toxicity profiles and comparison with first generation and second generation TKIs. And also one important point is if we start 10 patients with EGFR mutation positive patients with first generation or second generation TKIs, ultimately only 3 patients will be eligible to receive osimertinib in second line. See how among all these 10 patients, only 73 to 77% of patients receive second line therapy because some patients died during first line, or some patients because of poor performance status only given option of palliative care. Out of these patients, only some patients have eligible tissue biopsy for further testing, and some patients have inadequate tissue or invalid test results or get a false negative on plasma test. So for overall, for patients who are having valid test result, only 50% will be having T790M positive, others will be T790M negative. So finally, out of 10 patients, only 3 will be eligible to receive osimertinib in second line if you start treatment with second generation TKI in first line. Next slide. So let's see the sequencing data. Geotag study, this is a retrospective observational study of sequential afatinib and osimertinib in patients with EGFR mutation positive NSCLC. Next slide. In this study, they have analyzed OS overall survival of patients who have received efatinib in first line followed by osimertinib in second line, the median OS was 41.3 months. It is very good. But what are pitfalls in the study? Based on the study results, Geotech suggested reserving osimertinib for second line after failure on a TKI may result in better OS. But what are the drawbacks in this study? Next slide. As I said, it was a retrospective study, retrospective and observational analysis, and it excluded patients who were T790M negative or not tested, and also excluded patients who died on first-line efatinib, and excluded patients who could not receive second-line therapy. And also, in this study, the inclusion criteria also like that. Inclusion criteria, patients must have initiated osimertinib greater than or equal to 10 months before enrollment. That means shorter treatment durations were excluded. So finally, because of these drawbacks, it is not possible to draw conclusions about the relative benefit of sequential efatinib, osimertinib versus first-line osimertinib without a direct head-to-head comparison trial. So it is not possible to predict which patients will benefit from the Geotech sequence or treatment initiation. Next slide. So starting with first or second generation TKI and proceeding with osimertinib in second line for T790 mutation positive patient, this is not the optimal care because we are not smart enough to figure out who will get T790 mutation, and not everyone will be well enough to receive additional treatment. And the tissue or liquid biopsy is not always successful. And we have seen the good OS, very good OS benefit with osimertinib in FLARA study. Next slide. So finally, osimertinib is, because of these issues, osimertinib is the preferred first-line treatment for patients, NSCLC patients having EGFR mutations, and also in patients having brain metastasis. Next slide. This is the takeaway points. The median OS benefit of greater than 3 years sets a new benchmark for osimertinib, and it is the first. It should be the first-line treatment. And nearly 30% of patients remained on osimertinib at 3 years, and all patients subgroups consistently showed a positive benefit. And most importantly, its safety profile is also very good. So these data confirm osimertinib as first-line standard of care. Thank you.
Thank you, Dr. Pravina, for your excellent lecture. Next, let us go to safety point. You know, safety is the most important point when we decide on therapy. Whether the drug improves PFS or OS, if it's not safe, we think twice before using it. So let us see the safety aspects of osimertinib. Dr. Rekha Bansal from Apollo Hospital, Hyderabad, will be taking us through the safety aspects. Dr. Rekha.
Thank you, ma'am. Thank you for the opportunity. I thank AstraZeneca for the opportunity, and the slides have been provided by them. My job has been made very easy by Dr. Pravina because most of the matter has already been conveyed, and I think we are all convinced that osimertinib definitely is the choice. Now, why would this discussion even arise, the safety of EGFR TKIs? So, like Dr. Pravina was trying to highlight, maybe we would want to sequence, with decomitinib now available. Some might think, let us reserve osimertinib for a later line, maybe. But then again, like Dr. Pravina already mentioned, that the quantum of benefit is reduced, and only 3 out of 10 patients might actually be able to avail osimertinib. So very quickly, without repeating the slides, I will walk you through the safety of the EGFR TKIs. And like ma'am already said, efficacy is not enough. We need to even see the safety of the drug. So this all has been covered. I'm not going to be repeating all of this. This was also mentioned that in Asians, the EGFR expression rate is high. And in India, it is around 25 to 30%. I think we concur. This is what our office practice also shows. And the 2 most common mutations are exon 19 and L858R mutations. All the other mutations are labeled as uncommon mutations. So a lot has happened in the lung cancer field, and we are spoiled for choice. The whole question is arising because we have many drugs to choose from, and what do we choose? So effectiveness definitely matters, and we are convinced that osimertinib is the only drug to have shown OS benefit. Now let us look at safety also. This was discussed, so for the want of time, I will be skipping that. Safety. So why this discussion of safety again? So from the first generation to second to third, the change that has happened is the first generation were reversible targets and they had a reversible binding. The second generation had irreversible, and the third generation also had irreversible. But if you see, the non-target activity is very high for the second generation TKIs, and which is not there for the third generation. So the non-target activity is the one which is causing the toxicity. This was also shown. So though the second generation, we might think being a pan-HER2 inhibitor may be advantageous, but actually it is disadvantageous because we end up having a lot of toxicity due to inhibition of EGFR everywhere in the body, and so a lot of off-target activity. Whereas the third generation osimertinib has a selective EGFR activity, and it is irreversible. So again, that is advantageous. So this is a graph showing that as low the IC, the inhibitory concentration, obviously the activity is more. So if you see for the wild type of EGFR, the activity of osimertinib is really low, and whereas for the wild type, the activity of the first and the second generation is high, and that is why the higher toxicity. And this is a very busy table. So it is basically trying to say that the severity of the AEs, severity, also the frequency is higher for the first and more so for the second, and hardly anything for the third generation TKIs. So I'll walk you through this table. Like the table said, not only the frequency, but also the grade of the toxicity is higher for the second generation because more of off-target activity. And the most common side effects that we all have used all these drugs, and I'm sure we all are very much aware of what the toxicities are. So rash and diarrhea are more frequent, and they are in higher grade. So they are more with afatinib and decomitinib, and with erlotinib and geftinib also you see, but then because the frequency is less, the grade is also less. Between erlotinib and geftinib also there is a difference. So it has been found that the rash is higher among erlotinib receiving patients. I think this has been our observation in the clinical practice too. Geftinib can cause liver dysfunction, and the cause of this remains unclear. I'm sure we all have experienced this. So I have seen that erlotinib causes more skin toxicity, and geftinib does cause liver damage. So it all boils down to now choosing between decomitinib and osimertinib in case we want to sequence. So, and again, the whole question of L858R activity of osimertinib versus decomitinib. So as you can see very, very clearly, the toxicity with decomitinib with regards to any toxicity, whether it's diarrhea, paranoia, stomatitis, all of which is numerically higher for decomitinib. Again, cross-trial comparisons cannot be done, but you can see this will be a fair comparison because in both the trials, the comparator arms was a first generation TKI. So I think it's fair enough to have a comparison in this case here. This is again across, afatinib versus decomitinib versus osimertinib. So more than 3 grade A's, 49% in afatinib, 63% with decomitinib, which is a very high number, and osimertinib only 34%, leading to dose reductions or modifications. Almost 50% patients with afatinib undergo dose modification. We have observed it. Decomitinib I've hardly used. I have only, I generally start with 30 mg only. So yes, definitely it's a very toxic drug and a very high amount of patients, 66% patients, 2/3 of the patients requiring dose reductions or modification, whereas with osimertinib, it's only 4%. And I think we all agree, most of the patients of osimertinib, they are so fine that they don't even come back to us with any complaints ever. Once they are started on osimertinib, they are only coming back for their prescriptions, for their timely PET scans. So yeah, basically we are all convinced that the toxicity is less. And even with, so that was any grade toxicity. With regards to grade 3, 4, 5, which are actually more troublesome, they can interfere with the patient's daily life. And also sometimes very long treatment intervals are required. Sometimes with grade 4 toxicity, we might have to totally discontinue the drug. So that is very high with decomitinib. And despite the dose reduction, though the dose reduction was made in decomitinib, despite that, still the toxicity is higher with decomitinib even after the dose reductions. So this was mentioned by Dr. Praveena too. And this is more or less the repetition of the same. So this is just to say that most of the patients undergo dose reductions with decomitinib, and so 66% patients underwent dose reduction with decomitinib, and about 40% of the patients were reduced to 30 mg, and even 30% patients reduced the lowest dose possible, that is 15 mg. In my experience, I have never been able to give 45 mg to any patient. Post-hoc analysis, this is what I was talking about, that despite the dose reduction of decomitinib, still the toxicity is high. And as you can compare, if you remember the table from the FLORA trial, the grade of diarrhea, the percentage of diarrhea is still higher despite dose reductions. So that was about the safety. So I think, again, we are convinced about the effectiveness. We are convinced about the safety, that is osimertinib is very safe. Now let us look at quality of life. I feel quality of life indirectly is a reflection of the safety profile only. So if the drug is safe, and again, it is not creating new problems to the patient, and it is effective, it is decreasing the symptoms of the patient which are due to the disease, definitely the quality of the life of the patient will improve. So in Lux lung, so again, we are walking through from the second to the third generation. With afatinib, at least it did not deteriorate the life. But in Archer, we found that the decomitinib actually affected the quality of life. That is, it was poorer when compared to the patients who were receiving gefitinib. And in Flora, the osimertinib definitely showed better quality of life when compared to the gefitinib. So again, these graphs show what I had just spoken. That is, in gefitinib, the quality of life improvement was more when compared to the decomitinib arm. This is the table showing the quality of life measures which were used in the different trials. So in again, in first generation, definitely there was improvement with the use of the gefitinib and erlotinib. With afatinib, also there was improvement, but with decomitinib, there was improvement in the symptoms. But when compared to the gefitinib, in regards to global quality of the life, the data was favoring gefitinib. And with osimertinib, again, the data is favoring osimertinib because there were hardly any discontinuation or deaths. So management of adverse events, that is the most common adverse events. Again, the percentage of the incidence of the skin toxicity, which could be in the form of rash, dry skin, or pruritus, is very high with the second generation when compared to first and the third generation. Even the GI toxicity is very high with the second generation when compared to first and third generation. So how do we grade the skin toxicity? It is based upon the surface area involvement, less than 10% grade 1, 10 to 30% grade 2, more than 30 with desquamation, erosions, and vesicles is grade 3, and grade 4 is ulceration and denudation. So how do we manage? For grade 1 and 2, we don't have to stop if the patient is able to tolerate, and grade 1 is managed with topical agents. Grade 2, patient might require oral antibiotic. For grade 3, we stop the treatment for around 3 weeks, and then we might restart after the patient recovers at a lower dose also. For grade 4, it depends. We might, some of these patients might not be able to restart. Even with osimertinib, the management is the same. That is, if it is grade 3, we hold the treatment for 3 weeks, and after the recovery, we restart again. Diarrhea, we are pretty much aware of the grades. So grade 3 diarrhea, definitely patient might require admission. Grade 1 and 2 most often can be managed with oral pills like loperamide, residucarotol, and atropine. So there are certain warning signs. If the patient has nausea along with diarrhea, or it is affecting the performance status, patient has fever, sepsis, neutropenia, all of these patients are very critical, and they might need admission for their further management. So so like I said, grade 1 and 2, we generally manage with loperamide. The starting dose is 4 mg. After that, 2 mg every 4 hours until the diarrhea is controlled. The same thing holds true for diarrhea with osimertinib. That is more than grade 3. Stop it for 3 weeks and then restart slowly. So to summarize, definitely the second generation EGFR TKIs are more toxic, and the AE leading to dose reductions was very high in Archer trial when compared to the Flora, 66 versus 3%. Grade 3 AEs reported in 63% of the patients, and it affected the quality of life too. On the other hand, the third generation osimertinib is far superior in all aspects, whether it's efficacy, tolerability, CNS activity, and quality of life. And that is why it is the preferred drug of choice according to NCCN also. So thank you.
Thank you, Dr. Rekha, for your excellent talk on the safety aspects of EGFR TKIs. Coming to the last talk, this is by Dr. Bharti Devi, consultant medical oncologist from Omega Hospital. She'll be discussing on the critical aspects, critical factors which we need to consider when choosing therapy in early stage non-small cell lung cancer patients.
Good evening, ma'am. Am I audible?
Yes, you are very much audible.
I would like to thank Dr. Meherlakshmi Madam, the Global Oncology Forum, and the sponsors for giving me this opportunity. I would like to share my screen. Are my slides visible?
Yes, they are. Yeah.
Yeah, thank you. The topic I would be going to discuss is the clinical endpoints that are used in decision-making early stage lung cancer. The clinical endpoints are objective tools that we use to measure how beneficial a medical intervention is to a patient's feeling, function, and survival. We have multiple endpoints which will allow us to evaluate the outcomes independent of intervention, or that can be modified by the intervention. Usually we have primary, secondary, and tertiary endpoints. The primary endpoint, it is an efficacy measure. It will address the main research question like survival. The secondary endpoints, these are not sufficient to influence the decision making alone. They support claim of efficacy by demonstrating additional benefits like quality of life. We also have the tertiary endpoints which capture the outcomes that occur less frequently, or they explore novel hypotheses. They are the exploratory endpoints. We also have quantitative endpoints, which are the measured objectively by the amount of time that has elapsed from randomization or treatment initiation to the desired event. We also have qualitative endpoints, which are measured subjectively by the patient, caregiver, or the physician. We have different endpoints like overall survival, PFS, time to progression, EFS, DFS, time to treatment failure, and time to next treatment, which we will be discussing in the next slides. So in both the neoadjuvant, adjuvant, and advanced non-small cell lung cancer, do we need different efficacy endpoints? If so, why? The primary goal in adjuvant treatment is to eliminate the micrometastatic disease. The major problem with these adjuvant studies is they take long time. This is one trial of ECOG 1505 trial, randomized phase 3 trial, which is comparing with or without bevacizumab along with chemotherapy in resectable non-small cell lung cancer. The enrollment has begun in 2007 and it has completed in 2017, a decade long. But the results are negative, and so standard of care is not changed. The neoadjuvant treatment, it will downstage the primary tumor, potentially making the surgery less morbid and enables analysis of the treated tumor. What is the rationale for this neoadjuvant studies in resectable non-small cell lung cancer? They will help us to rapidly evaluate the efficacy without waiting for overall survival as an endpoint. For this, we use various surrogate endpoints. The time to rule out the drug is 1 to 2 years instead of 7 to 9 years that are used for the adjuvant trials. But there are various challenges with these studies. The evidence supporting this tumor response as a surrogate is solid, but they are no validated randomized phase 3 trials yet. and it is also not yet standardized. So what are the surrogate efficacy endpoints we have in both adjuvant and neoadjuvant setting? The clinical endpoints are overall survival, DFS or recurrence-free survival, and event-free survival. We have pathological endpoints like PATH-CR and major pathological response. And we also have surgical endpoints like pathological complete resection, that is R0 resections. So why do we need surrogate endpoints? As I already told, overall survival, though it is a gold standard, it takes many years for the results to come. And so for these surrogate endpoints, we need earlier assessment of, they will tell us about the earlier assessment of the treatment benefit. And greater number of events allows smaller number of patients in the trials. Surrogate endpoints, what are the criteria they should meet? They should predict the overall survival, they should predict the treatment effect on the overall survival, and they must be validated for specific therapeutic classes. So in neoadjuvant non-small cell lung cancer trials, what are the pathological? These graphs show that in patients who have less than 10%, when compared with more than 10% viable tumor cells, there is overall survival benefit in those who have less than 10% viable. So it is also seen with the recurrence-free survival in the first two graphs, and also in the next two graphs, the major pathological response, who are having major pathological response, there is overall survival benefit. So this says that if there is good pathological response, it is going to predict the survival. PATH-CR and major pathological response, are they both same? No, both are different. PATH-CR, it is usually defined as no detectable evidence of tumor based on histopathological evidence. In lung cancer data with neoadjuvant treatments, we usually see low PATH-CR rates like less than or equal to 10%. The major pathological response, what is its criteria? There is presence of residual viable tumor in the resected tissue. We have a cutoff of less than or equal to 10%. The PATH-CR has been used as a surrogate endpoint for approval in neoadjuvant breast cancer, but its usage in lung cancer is not yet good. So what is the evidence of this PATH-CR surrogate endpoint in neoadjuvant setting? There are a few phase 3 trials where they showed that 8% of the patients has achieved PATH-CR rate. They showed that PATH-CR is associated with overall survival with neoadjuvant chemotherapy, but the number is less. We have another, as I already told, major pathological response. It is measuring this major pathological response is a tedious process where we see multiple H&E stained slides of the resected tumor specimen, and we calculate sum of percentage of these divided by the number of slides that we see. So for this as a surrogate endpoints, these graphs show that if there is major pathological response, there is a survival benefit when compared with there is no major pathological response. These are seen in both prospective and retrospective trials who have received neoadjuvant chemotherapy. So what are the pros and cons of these two surrogate endpoints? Both of these help us to early assess the treatment effect. And they need short trial duration and follow-up. They are not influenced by the treatments that are administered after recurrence. And effects of on the tumor attributable to treatment is not natural history of the disease. What are the cons? These are not yet validated as surrogate endpoints in the neoadjuvant setting. Different trials have different definitions for this, and they may not correlate with the survival all the times. The PATH-CR rates, they are low with the neoadjuvant therapies in non-small cell lung cancer, like less than or equal to 10%. So requiring large patient cohorts to demonstrate significant limits of feasibility. The major pathological response, there may be inter-observer variability in pathological assessment. These are few trials, phase 1 and phase 2 trials, where they have used neoadjuvant EGFR TKIs or immunotherapy, and but there are not yet matured phase 3 trials where they have validated this PATH-CR or major pathological response. So we need further trials and data to see whether these PATH-CR or major pathological response, whether the benefit is going to translate into overall survival with EGFR TKIs and immunotherapies. So the neoadjuvant treatment, usually we give neoadjuvant treatment followed by surgery, and we see the clinical outcomes. So so far we have been using chemotherapy. There are ongoing trials where we are using instead of chemotherapy, immunotherapy and TKI along with the chemotherapy, where we want to know whether they are going to increase the PAT-CR rates or the major pathological response to see the overall survival benefit. The trials are underway. So in case of resectable non-small cell lung cancer, what are the clinical endpoints? In the adjuvant setting, we have the disease-free survival. It is time from randomization until disease recurrence or death from any cause. It is also known as the recurrence-free survival. The DFS and PFS both are slightly different. This DFS has gained an approval for adjuvant breast and colon cancer therapy. It is also recognized as suitable primary endpoints for adjuvant trials, like include the one that we discussed, like Edward trial. So is DFS an appropriate surrogate endpoint for overall survival in adjuvant non-small cell trials? Where we have seen in case of adjuvant non-small cell setting where we have used chemotherapy, the DFS has predicted the overall survival. So the correlation graph is showing all the aligned circles coming around the point 1 where they are showing there is correlation between overall survival and DFS for adjuvant chemotherapy. But in case of the adjuvant EGFR TKIs, this has not been translated. They have shown higher 2-year DFS than the historical controls. There is around a 2-year DFS of 91% for stage 3A, 5-year OS of 86%, but they are not yet mature. Overall survival has not yet been demonstrated in this select study. So this is another trial, phase 3 trial, adjuvant CTOM trial, where they showed DFS benefit, but it has not been converted into an overall survival benefit. So this is a graph, this is a meta-analysis showing with the use of adjuvant TKIs, there is clear DFS benefit, but the overall survival benefit is not yet converted. So DFS has not been validated yet as a surrogate endpoint for overall survival in trials which have used EGFR TKIs. And in case of immunotherapy trials, it needs to be demonstrated, determine whether DFS is going to predict overall survival or not. Results are awaited. So overall survival, it is the gold standard endpoint in clinical trial. It is unambiguous. It is simple to measure, easy to interpret, and unbiased measurement. But the cons are it needs long-term follow-up, larger sample sizes are needed. It is affected by the subsequent treatments like crossovers, and there are risk of non-cancer deaths. And the DFS, earlier measurement of the treatment effect, shorter trial duration and follow-up, and it is not influenced by the treatments administered after recurrence. Smaller patient cohorts are required, less influenced than overall survival. There is delay in recurrence is meaningful to the patients, but this is not yet validated as a surrogate endpoint in trials using EGFR TKIs or immunotherapies in adjuvant non-small cell lung cancer. So this is various trials like where they use neoadjuvant immunochemotherapy ongoing trials. So summarizing, overall survival remains the gold standard efficacy endpoint, but requires long follow-up and large patient cohorts. DFS has been validated if endpoint for overall survival in adjuvant chemotherapy trials. There is some evidence for association between PAT-CR and major pathological response and overall survival in neoadjuvant trials, but they need to be regularized. And there is evidence needed for larger trials to validate surrogate endpoints in EGFR TKI and immunotherapy trials in non-small cell lung cancer, resectable ones. Thank you.
Thank you, Dr. Bharti, for your excellent talk. You have made a job easier. It's a very difficult topic, which you made it very simple. And today evening, I'd like to thank the AstraZeneca and the organizing team for giving us opportunity to present all the topics. And it has been a very good session. Thank you one and all. I thank all the speakers and all the panelists for the excellent job. And thank you once again. over to the organizers.
Thank you, ma'am. Thank you all the speakers for taking active participation in the webinar today. There was a very good learning, and I would like to request the team to stop the recording and we can conclude the session. Thank you, everyone. Good night.